As the name suggests, it is the inflammation of the glomeruli. And its etiology, it has multiple etiologies, and as we can be familiar with, most of them come with an autoimmune event, especially SLE. Before SLE, if the presenting illness was only in the kidney, they usually called it a specific limited lupus. But today, with the current criteria of 2019, COVID-19, having ANA with lupus, with nephritic syndrome is enough to diagnose lupus nephritis. Or as I was saying, having nephritic syndrome with ANA now enough is to diagnose lupus erythematosus. And the classification will be presenting on the clinical symptoms, the pathology, and the immunogenic finding, which will help us to guide the treatment for the patient. So according to the glomeruli will have two umbrellas of syndromes, one of them nephrotic and nephritic. And based on the etiology, it could be classified into primary and secondary. Primary, mostly the cause it's not specific, multiple causes, while the secondary, yes, idiopathic. As for the secondary, there's a leading cause that led to the glomerular damage. So according to pathological term, I think most of them have been mentioned briefly in the acute kidney injury lecture. We will now dive more into them. The minimal change disease, focus, this is a childhood disease, exactly. It depends on the history more than the significant findings, because in light microscope and immunofluorescence, there will be no abnormal findings. In the electron microscope, if you were, or the lab specialist was an expert, he will see there is a slight diffusement of the podocyte processes, I suppose. And then we have focal segmental glomerulosclerosis, this is nephrotic syndrome, membranous nephropathy, IgA nephropathy, post-infectious glomerulonephritis. But now it has more.
Nowadays سموها post infectious because it could be caused by
all
bacteria, all viruses, even chlamydia, even parasites. شنيتها سموها صح post infectious.
And lupus nephritis, which most of the lupus patients suffer from, unfortunately, and ANCA-associated glomerulonephritis and anti-GBM. So it could be an acute, it could be classified as the history of the presenting illness, whether it came in a short period of time as an acute glomerulonephritis, or on the term of long-term chronic glomerulonephritis. As for the acute, as was mentioned, the post-infectious glomerulonephritis, the presentation comes with a child after having an upper respiratory tract infection, 1 to 2 weeks could come with the presenting symptoms, which is frequent hematuria, edema, but not as drastic as the nephrotic syndrome causes. And other specific findings. And rapidly progressive glomerulonephritis, this term has multiple diseases, one of them which is anti-GBM disorder, and lupus nephritis, and the last one, I presume it's membranous progressive glomerulonephritis, which is the last one. And the ones that progress slowly is IgA nephropathy. As for IgA nephropathy, it is quite to mention that the symptom that the patient might suffer would be only frequent hematuria with no other symptoms. And the hematuria may not be gross, it could be microscopic. And hereditary nephritis, which is Alport syndrome. Alport syndrome is the history-based diagnosis because the findings are, you could say, in random. So when trying to diagnose it, focus on the history and with significant findings of sensorineural loss, vision abnormalities, and kidney renal symptoms, and thin basement membrane disease. As I was saying, it is characterized by symptoms which most of them us know that is hematuria, with RBC cast or dysmorphic RBCs. In hypertension, due to the GFR is decreased due to the inflammation that happened to the blood. So the RAS system will be activated to retain water and sodium, which will then lead to hypertension of the preload, and then edema, which will follow the hypertension, and mild to moderate proteinuria. There is a proteinuria, but it won't be as drastic of the nephrotic syndrome, less than 3 grams per day. But some of the conditions, like in lupus or membranoproliferative glomerulonephritis, could go to the nephrotic syndrome. So we will have an overlap between the nephrotic and nephrotic criteria. We will have increased serum creatinine as usual, there's a kidney damage, and oliguria most often, due to the decreased glomerular filtration rate. And there is the constitutional symptoms such as a headache and fatigue. As for the pathophysiology, it depends on the disease etiology. If we said due to infection as in post-streptococcal or post-infectious, or could be an autoimmune like in lupus, or other systematic conditions. These are due to immune-mediated inflammation. In general, the immune-mediated diseases, they don't like to contain themselves in one organ, they like to hit multiple organs. And which leads to damage to the capillary walls. And this increases the permeability, which allows RBCs and some protein to leak into the urine, which will lead to the hematuria and visible proteinuria and decreased GFR. And depending, and now if we want to classify nephrotic syndromes according to complement levels, it will help us to define, especially if, as we've seen, that most of them are immune-related. So we have nephrotic syndrome with low complement, meaning if we have low complement, meaning they are being used. So we have immune deposition on the kidney, which leading to the damage, which is mostly seen in post-infectious glomerulonephritis, which lead to subendothelial deposits, if I'm not mistaken, or subepithelial. Subendothelial, they appear like being humps in the electron microscopy. And we have the membranoproliferative and lupus nephritis. And nephrotic with normal complement, meaning this, the complement system is not being used, so there is no immune deposits directly. We have IgA nephropathy, and its variant Alport syndrome. And we have, this is a signal entity, the Henoch-Schönlein purpura. Henoch-Schönlein purpura. Henoch-Schönlein purpura is the variation of IgA nephropathy, but with extra manifestation, with the purpura within the legs and the buttocks, and GI manifestation due to the not immune deficits, due to some IgA mismatch in the GI system. And anti-GPM disease, which is for good posture, the good postures disease, which is very specific to that, and ANCA-associated glomerulonephritis, which is resulting as a vasculitis of the small vessels. And the glomeruli is considered a small vessel, so it makes sense. Doing investigations, one of the most important ones will be urine analysis, which will make us see the hematuria and the red cast. Creatinine and urea is a no-brainer. C3, C4 to see if the condition we are dealing with is a low complement or rather a normal complement. ANA, anti-dsDNA if you suspect there is lupus or not. ANCA, if you suspect of a vasculitis-related disease such as Wigner vasculitis, Churg-Strauss vasculitis, or GPA if I'm not mistaken. And anti-GPM antibody if you suspect of good posture and the symptoms from the history and the physical exam makes sense so that we could ask for this test. For hepatitis B and C serology, it is more likely seen in membranoproliferative glomerulonephritis and as a secondary cause, because these diseases are chronic in general, so the antibodies may react with the antigen presenting on these viruses, which will lead to immunodeposits if in the subepithelial or the basement membrane. I don't remember exactly where the deposits are. As for the hepatitis B and C serology, I know that due to their chronicity, the antigen will react with the antibody and leave deposits somewhere in the GPM. I just don't remember if it was on the GPM itself or rather subepithelial. Renal biopsy is crucial in unclear or severe cases. Though renal biopsy gives us the easy clue and the easy answer for our diagnosis, but a biopsy is not as easy as it seems, especially especially knowing that a biopsy, especially if knowing the patient, if mostly they are unstable, and after the biopsy, is instead of making them feel better or for the better, it will make them go for the worse. The symptoms that were maintained will go a downward turn, a sharp turn. So a renal biopsy is not always maintained. For example, as for it is a nephrotic syndrome, which diabetic nephropathy, and even SLE, nephritis, we don't usually require a biopsy because the symptoms are enough to diagnose the disease. Yeah, it's very obvious. Even though the renal biopsy sections are quite unique and diagnostic, but there are other relatives. Okay, diseases. To dive in with one diseases. First, post-streptococcal glomerulonephritis or infectious. Let's go with it. Okay, skip. Diagnosis, as I said, from the history, if they had pharyngitis or impetigo, and post-infectious. And skip it. Even there. Yes, it is the worst one, which will lead to a very sharp decline of the renal functions and lead to renal failure. And one of the diseases that could lead to rapidly progressive glomerulonephritis is the anti-JPM, unfortunately. And immune complex diseases, they have a granular pattern of immune complex deposition. As for the type of the immunoglobulins that are deposited, it differs. It could be a full house, IgG dependent, IgA dependent, dependent on the disease, the presentation. Or we have Pasui immune disease. Pasui is from the Latin word posi. Posi is from the Latin word, and it is mostly seen with ankle-associated vasculitis because it doesn't deposit that much, but it is quite diagnostic there. Will I go on with this one? Okay, with anti-GPM, good posture, the antibody is predominant is the IgG, which develops against the GPM. Type 4 collagen that is located within the GPM of the kidney and the alveoli in the lungs, I guess. Alveoli in the lungs. And they deposit in a very special pattern, which is a linear pattern. It is the only one that they deposit as a linear pattern. And it has a bimodal distribution. It could occur as a first peak in young men, less than 20 years, or second in older men and women, 60 to 70 years. And it could lead to pulmonary involvement, which is more frequently in smokers in the younger age, except group. It could have an explosive hemoptysis with a fall in hemoglobin, fever, dyspnea, and hematuria. The prognosis is unfortunately bad, especially if it was a multi-organ involvement. In diagnosis, serum anti-GPM is enough to cause, and we need urgent kidney biopsy to see what kind of management we have to do with this kind of patient. And as soon as you diagnose the disease, you have to start treatment even before the biopsy is taken. If anti-GPM is positive, you have to start with the treatment even before the kidney biopsy to be able to maintain or have a decent prognosis with the patient. Treatment will be any autoimmune disease will have high steroids. to lessen the inflammation. Cyclophosphamide. Cyclophosphamide. It is an alkylating agent which is used to suppress the immunity of the patient. And plasmapheresis. For plasmapheresis, we do go to that route if the renal functions is declining rapidly. If the renal function is declining slowly, or there is a plateau in the renal function, we go with the steroids, cyclophosphamide. An isolated renal involvement needs less aggressive treatment. If it was multi-organ, we need more aggressive treatment. As for ANCA small vessel vasculitis, we have 3 types. The GPA, which is known as Wegener granulomatosis. بظنكم بتتذكروا من المحاضرات الروماتولوجي كانت عن العالم النازي. Patients will present with the patients will present with respiratory usually upper, but also lower and renal symptoms. It is a disease of an old age. And we will have fever, purulent rhinorrhea, nasal ulcers, sinus pain, and polyarthralgia of arthritis. It does overlap with Churg-Strauss syndrome of the pulmonary inversion presentation, but what differentiates it from its ANCA? We have 2 ANCA. We have cellular and paranuclear ANCA. This disease is frequently positive with C ANCA. It could go to the retroorbital. It could cause the retroorbital inflammation, as is seen here, leading to diplopia. An X-ray will reveal nodules, and what they call sometimes cavities. But the ANCA can spare the kidneys, where it's called limited GPA. Why does it spare the kidney, which is abnormally? Because in the ANCA-associated vasculitis, deposited is not directly on the vessels of the glomeruli. Rather, it goes somewhere else. I think it was in the monocytes or neutrophils, which then these 2 cells will cause damage on the long term. Treatment, as same with the GPM steroid, with immunosuppression. Okay. Microscopic cholangitis. Okay. Okay. IgA nephropathy, also called Berger's disease, not an German word. Berger disease. And out. Yeah.
هم مشان يخلصوا من هذه القصه جابوا الاي جي اي
It is an immune complex disease, an IgA antibody deposit in the mesangium of the glomeruli, not in the GPM.
Is that common?
Yes, the most common type of the glomerulonephritis. And it has more common in males, and has a peak incidence in the 2nd and 3rd decades of life. But though it could happen to children more too. It could be either idiopathic, primary, or associated with other diseases, including chronic liver disease, Crohn's, gastrointestinal adenocarcinoma, celiac, dermatitis, herpetiformis, chronic bronchiectasis, idiopathic interstitial pneumonia, mycosis fungosus, ankylosing spondylitis, and Sjogren syndrome. Sjogren syndrome, the disease of the eyes and mouth. Sjogren. Yeah. Of the mouth and eyes. But it's more frequent, huh?
النسوان اللي ماتوا يقولوا فلان حضر ابوها مات وما بكى بجوز عندها شوك.
ايوه.
فدائما نظلم يعني بسرعه.
and it has a gross hematuria 1 to 3 days after upper respiratory infection. This is why it's important while taking a medical history, if the patient actually answers that they had an upper respiratory infection, to ask of its duration. Because if it was from 1 to 2 weeks or 2 to 3 weeks, we have to think of post-infectious glomerulonephritis. While if it was only for brief days, 1 to 3 days, we have to think of IgA nephropathy. It is usually asymptomatic. The only symptom that the patient will be facing will be recurrent microscopic or macroscopic hematuria immediately after upper respiratory tract infection. It could have proteinuria or persistent asymptomatic. Acute renal failure and rapidly progressive clinical picture is rare here, which makes the prognosis for the kidney very good. How to treat it? The treatment is supported. We have to treat the symptoms and to elevate them. IC inhibitors or ARBs be used if there is proteinuria to maintain 24-hour urine protein. لا لما تخلص النفروتيك سندروم. لا والله لفينا مع روتيشن نفرو أسبوعين. The IC inhibitors or ARBs can be used if there is proteinuria to maintain a 24-hour urine protein excretion less than 1 gram and a blood pressure less than 130/80. Immunosuppressive therapy must be considered if there is persistent proteinuria, progressive kidney dysfunction, and histological finding indicative of rapidly progressive glomerulonephritis. That if we ever mention to take a biopsy. Lupus nephritis, which is a very common and a serious complication of systematic lupus.
Very important. Young means between 20
سمعتك يا
and
أحمد.
مش young than teens. Teens هذول يعني delayed childhood. لما نقول young between 20 و
As I've mentioned before, patients with systematic lupus erythematosus may have only the presentation of lupus nephritis alone, which made very bad decisions because if we mention that the criteria for lupus has 11 criteria and has to be 4 out of 11 positive with ANA serum positive. But now with the new criteria in 2019, it made the findings and diagnosis more accurate by the point system. Having nephritis alone gives you 10 points, which is required for diagnosis, beside the ANA positive serum. And the most common clinical sign is proteinuria, unlike of hematuria. Hematuria will vary with the varying renal failure, depending if it progresses to rapidly progressive glomerulonephritis or not. And this is why lupus nephritis is in the middle spectrum between nephrotic and nephritic syndrome. And
So any young lady presents with proteinuria, isolated proteinuria, if you are a broad-minded physician, you have to do lupus work.
yes, like including the anti.
Because the commonest organ which is affected by lupus is the kidney.
Yes.
And the commonest renal manifestation of the kidney is proteinuria.
If we want to remember about the lupus workout, which is the anti-ANA, anti-dsDNA, and anti-Smith antibodies, which will help us to make a diagnosis. And do not ever jump to kidney biopsy, no matter how easy and tempting it is, because it is very hard on the patient itself. And it has 6 classes. They differ in their presentation and no need.
Lupus nephritis, class 1 to 6.
Because if it's an autoimmune disease, the complements will be usually low. We will have a serum, C3 and C4 low, ANA and anti-dsDNA will be elevated, and all lupus will have acute active urine sediment. هاي ما شفتها. هاي ما شفتها لما كنت بدرس. كيف بتكون دكتور؟ And regardless of the GFR, all candidates are candidates for biopsy. Is this true? Is this true? When we were taking our rotation in nephrology, in nephrology, the doctor said if you suspect and all the signs are leading to lupus nephritis, we don't need to do a biopsy. Especially,
Kidney biopsy, it is a must in lupus patients because of the three causes. First, it is diagnostic. Second, it is prognostic. الدكتور of which class? Class 3 or 4? Sometimes there is a transformation. يعني السنة كان class 3, السنة الجاية يكون يصير class 4. So اللي قال إنه biopsy is not a must is wrong. Three goals for kidney biopsy in lupus: diagnostic, prognostic, and therapeutic. كويس إنك
perhaps it was a contraindication for it because perhaps there was a lab previous report because the patient was she came through the clinics and her case was well diagnosed, so I don't know why.
If she is well diagnosed, biopsy probe lupus. No need. يعني as a baseline we have.
Okay.
Therapeutic biopsy تعطينا which class. هلا every class has the best medication.
بعرف الكلاس وبعرف شو بدي اعمل.
What is the best medication for that?
With the biopsy results, we can see under the light microscope there is capillary loop thickened wire loop. Okay. Okay. With membranoproliferative glomerulonephritis, there is an immune complex formation secondary to chronic antigen stimulation. There is two types, type 1 and type 2. In type 1, we will have the IgG, non-immunoglobulin specific would be IgG. With type 2, there is the nephrotic factor. In type 1, the patient will have a history of a recent upper respiratory tract infection, which usually manifests as nephrotic syndrome. This is the second disease from the nephrotic syndromes, which will come between nephritic and nephrotic. So the proteinuria will be within the nephrotic syndrome sometimes. And we said that, and it manifests in type 2, which is dense deposit disease. It is less common, and it usually presents as
3 Ds. Deposit disease.
It will present as a nephrotic syndrome, unlike its the type 1, and it is associated with hypocomplementemia, and its T3 nephrotic factor is positive. So common causes for that, we will have chronic indolent infections, as I said, syphilis, hepatitis C, B, mastoiditis, autoimmune such as Sjogren, lupus, and essential cryoglobulinemia, type 1 and 2, malignancies such as carcinoma, sarcomas, lymphomas, and leukemias. Treatment by cortisone and antiplatelet drugs such as aspirin. Is there fear of having a DVT or something like that?
Why antiplatelet?
By cortisone and antiplatelet drugs.
Why antiplatelet? Because in this disease there is what is called platelet aggregation and liability to thrombose. So you have to treat that.
Okay. And it is one of the diseases that progresses to rapidly progressive glomerulonephritis, which 50% of the patients unfortunately will have end-stage renal disease in 10 years. No, even if they were properly managed, even with proper management. هنا شوية
على ذكر النقطة all diseases of GM اللي هم about 41 disease. The best management is not enough to يعني to finish the cycle of end stage disease. يعني وقف الدواء اسبوع يا مريض وكثير بيجي لك متنفخ ومسكر. فالديت يعني لو عالجناه in the best hospitals in the best hands هذا لا يعني انه he will not develop end stage kidney disease. يعني we are delaying the complications. Just فيعني اذا في مرض في الدنيا او وحده 40 مرض يسودوا وجه النفرولوجيست هي الجي ام، لانه ما في حل جذري راح ينتهي كدني
Henior Scholian purpura, which is at the subtype of
كلكم شفتوها يعني
هنا
هناك شورلاين، هذول المان،
اسمها
هم المان، هناك شورلاين.
It is a subtype of IgA mediated
لا
vasculitis.
هم المان يقولوها هنوك شورلين، اللفظ الانجليزي هنوك شورلاين.
The type of the IgA in the vasculitis in the small vessels, but they have multiple.
هاي الصورة بتجيكم ترى بالميني اوسكي، في عندكم بالميني اوسكي بيجيكم كم سلايد، كم اي سي جي، كم تشست اكس راي، مرة جبناها.
Classic manifestations, we have to think of the three types: skin, of the skin, renal, and joint. It will lead to pain, joint pain, arthralgia, and abdominal pain, diarrhea, and bleeding. Purpura, it could be purpura or petechia, more on the lower extremities. Petechia, more on the lower extremities. Renal, which will lead to glomerulonephritis. The most accurate test is biopsy, but the IgA levels are not useful in this case scenario, unlike it's of its limited disease. And no treatment is necessary. We have to, the resolution is spontaneous. We just manage the symptoms. It is just a support of the treatment. Alport syndrome, this is an inherited X-linked.
عندي يعني هذا الفورت تيجيني ام بتجيب معها ولدين وبنت، انا بحزن عليها، تيجي 3 مرات بالاسبوع، بتغسل كلى للولدين وللبنت، وفوق ذلك انه عندهم كدني فيلير، في عندهم ديفنس، فايتز الفورت سيندروم، في عندهم فيجن بروبلم ولا بتشوف، يعني بتحزن هاي الام اللي 3 مرات بالاسبوع جايبه 3 اطفال على
It is X-linked, so from the X-linked, I think the males are more prone to get hit with this disease. Genetic mutations, the genetic mutation in this disease, it affects the alpha 3, 4, and 5 chains of the type 4 collagen, which is present in the GPM of the kidney, and the collagen of the eyes and ears, which explains why there is a vision problem and a hearing problem. It could lead to sensorineural hearing loss, meaning the problem is in the nerve, not a conduction system. And visual disturbance from the loss of the collagen fibers that hold the lens of the eye in one place. A classic triad will be hematuria, hearing loss, eye abnormalities, and from history it will be a young patient, and there will be a positive family history most likely. Electron findings include alternating areas of thinned and thickened capillary loops with the splitting of the glomeruli in the GPM. We said we want to suspect the output, especially if we see this triad and with recurrent episodes of hematuria. And if there's a positive family history, and unfortunately there is no specific therapy to reverse this defect of type 4, perhaps in the future.
شكرا جزيلا. يعني تستحق العلامتين بجدارة.
الله يكرمك.
خياري وين بدنا نروح؟ To which area؟
ترى تعبان مدري.
سمعينا
تطلع تطلع خايف نادي بس خلاص عندك.
ليش ما نعمل له ايش؟ هلا مثلا يعني احنا نوديه على كدني ترانسبلانتيشن وهو لسه نقدر نخليه على كدني ترانسبلانتيشن 10 15 سنه. تنسيش انه الكدني ترانسبلانتيشن it is a solution of kidney failure, but it is not that golden solution. The golden solution is the native kidney which is created by Allah. يعني نضل نستفيد من الكدني عشان تبدا. واضح؟
تك حاضر نفسك.
يلا اسمعي خلي شنطين ماشي.
كم سلايد؟